So welcome to what is probably your second. Today we're going to talk about downstream system consultation and its role in enhancing culturally responsive suicide prevention services. I am going to set myself. I could talk for about an hour. I don't have a lot of slides, so I know this is not an optimal view of slides here. But this is not about the slides, this is about our discussion today. So I'm going to give us a little bit of background on the slides, we should be fine. And when I get there, I could talk for about an hour on each of the slides. So I'm going to set myself a timer and see how much I can not talk so that we can get to the good stuff. My name's Chris Weaver. I am a clinical psychologist. I identify as a forensic psychologist, which brought me into the world, interestingly, of psychological trauma, offending. How is it that we are criminalizing mental illness? That's a big piece of what drives me. And that brought me into suicide prevention. My friends tell me I'm now a full-fledged honorary stamp-holding member of suicidology. So I've been gravitating towards that work for the past probably decade or so. And so have been doing more community mental health work and suicide prevention. I'm a professor at Palo Alto University. I run our forensic psych area of emphasis up here, along with my colleague, Dr. Joyce Chu, who runs our diversity and community mental health track. She can't be here today. She is one of us, one of the presenters for today and one of the partners on the project. She will come in and talk to you all about Be Sensitive, Be Brave this afternoon. She is teaching 30 brand new, bright-eyed PhD students psychopathology as we speak. And I need to leave out of here somewhat unceremoniously to go teach them ethics. So that's the pace of our schedule today. So joining me today are a couple of folks who it has been a distinct pleasure to work with them. You'll see, I hope you feel the theme of camaraderie and collaboration and work that this project is describing here. And we've got a couple of folks representing Momentum and Acme here who have been in the trenches with us during this project and doing the work. So first up, Dr. Shefali Miller. She's Chief Medical Officer at Momentum for Health. She's been there since about 2019. She went to med school at Columbia University and her psychiatry residency was at Stanford. She, at Stanford, was a clinical assistant professor and ran the specialized bipolar disorder research and treatment group there for some time. He's here representing Momentum for Health. From ACI is Dr. Vandy Loth. Dr. Loth is a national board certified psychiatric mental health nurse practitioner. She has her master's of science from nursing from UCSF. She completed her master's in public health and doctor of nursing practice at San Jose State University, Spartans. She is a program manager for the integrated behavioral health program at ACME, and she does a number of patient service and training supervisory roles up and down the chain. Both of those folks have been instrumental. You'll hear us talk about this work succeeds when you have champions, and they've been a couple of the champions within their again, I'm going to go through this in a way that makes sense to me. I have lived these slides for the last 4 years, so they may not make sense to you. Feel free to throw a hand up and say, wait a second, what was that? Or slow me down. But again, what I'd like to do is give us a bit of the backdrop and a bit of the data that kind of show why we think what we are doing is working. And then we'll come up here together and we have some prompt questions for me to start with them. And then we want to turn you all loose on them too. And see what you can pull out of them for this. Here begins I want to try to keep it. Any other data nerds in the room? We've got good data here, so that's the problem, all right? So again, spend a lot of time. So this started from the Suicide Prevention Oversight Committee and then through Suicide Prevention Services, credit to Megyo Lien, who's not in the back taking pictures and having me point her out right now because she told me not to do that. And we had other folks who were constantly there. Jay Donahue, who's floating around, looks a little like Woody Harrelson, walking around out there. And then more recently, Jen Kang. So those folks have been deeply hands-on from the vision of the project to the supervision of the project to watching it and seeing how it works. And the intention here was that Spock had identified through some needs assessment in the county, we're doing this well, we're doing that well, we're putting a lot of effort into here, but we're not putting a lot of effort into downstream prevention or downstream services, enhancing the way that agencies are out there dealing on a system level with suicide prevention. And one of the things that's difficult to do that is that there are a couple of ways to do it. One is you go across the system and you tell them what they should do, which ends up not working for any part of the system, and folks won't do it. Or you go in custom, site by site by site, see what they need, you see what they're excited about. You build the internal and external expertise to make those things start to happen, which is in terms of people time, very expensive, but it will stick. You can make it work. It's sustainable. And that was ultimately the goal with, again, the end mission being to prevent suicide death. The idea of the project, the first thing that we did is we did a pilot project. We started a rollout, and we thought that it was working pretty well. And we said, okay, if we grew this, where would this go? And the hope and dream, I think, is that one day within the county, each of these cogs in the machine are cogs that we are touching with this kind of service somehow. What you're going to hear from today is really the bottom cog, the CBO and specialty mental health folks. We have done some work with primary care, and the current year we are getting into that county behavioral health clinic. All the while, we've been trying as best we can to keep up and keep coordination with the crisis hotline and mobile crisis folks who have been, as you may have noticed, changing and moving a lot in the past couple of years. So we stayed coordinated with them, but to keep the integration strong throughout what we've done. This is what our list of kind of consultation things looks like. This is how we have to write it for funding. What this means basically is we want to be able to go in to a site and really say, hey, how are you all doing? What's going well? What strengths do you have that we can leverage those? What challenges do you feel like you have? And how do we fill those gaps? And what we want is the ability to stay flexible and move around to whatever the organization tells us. And it's important too that we have defined the organization as anybody there working. We believe that anybody in the organization is there with a shared common goal of providing the services that they provide, and that everybody has a vested interest in these things going well or changing or getting better. And this is from licensed clinical staff, front desk staff, whoever it is, janitorial staff, whoever it is. Some of the driving ethos behind the project is somebody at an agency knows about every single problem and challenge, and there's probably some really good brainstorming out there about things that could be done to make it better. Somebody knows. So if we can get them to talk to us about that, we'll be able to see it and at least lay something open and start to move steps. So let's start with momentum. So it's important to say the way that these sites were chosen was we wanted to go into sites that were known to be high functioning, but also serving a high acuity of folks and a large number of folks at high acuity. We wanted to be somewhere where suicide prevention was extremely relevant, but we didn't want to go into a system that has a reputation of being broken. Not that I don't know if there are any systems that have the reputation of being broken, but we didn't want to go in and have to try to fix something. We wanted to be able to go into a place and be able to accentuate a place that appeared to be working well. And Momentum and Aki and Gardner, a number of these different sites came up, and we just ended up connecting and starting with Momentum. We actually made initial contact with David Mineta, who I remember who heads Momentum for Health. I remember a meeting where I believe he had a suicide prevention T-shirt on. He'd probably just come from a run or something. And the committee was starting, and we said, look, it's going to be important that we can make real change here. And he basically said, anything the committee will do that. And you'll see, again, the theme of a champion can make these things work, and struggles up above can make these things not work. So we did our needs assessment at Momentum. Things came back, and we had some pretest data that I'll show here in a bit. But what we decided for Momentum, what they needed and what we wanted to pitch to them and see if they would get excited about was a 6-month series. And 6 months starting in September. So for Suicide Prevention Month, could we launch and say we're going to do a 6-month series with a topical thing following each month post-September. And instead of just kind of having a month of focusing on suicide prevention, can we do it for half a year and what happens? And they loved it. And so what we did was basically this. We went in, and these are going to sync up with the needs assessment results that we see. But they wanted to do the first month on culture and underserved populations so that that could underlay the entire effort. We wanted specifically to come in and talk about assessment and documentation. And then a theme that keeps popping up and has popped up everywhere since is actually staff support and support of the people working following a death by suicide among the patient population or even among the staff population. Okay, so credit to Zero Suicide folks for putting us on the track of assessing for this. It is a need that makes so much sense and is often, I think, missed out there. These are hard jobs. We love doing them, but when this stuff happens, we need support. Safety planning and treatment, and then crisis in 5150 would wrap things up. And then the goal for each of these was we would have one training on topic for each of the months, and we would try to make one sustainable institutional change. Not a gigantic change, but one sustainable institutional change that had something to do with this topic area. For example, in culture and underserved populations, we got translations of the Columbia Screener in a number of different languages, and we got them hooked up and trained on the cultural assessment for risk of suicide. So that was an underlayment then that we could leverage throughout the rest of the effort, and those things are now, at least in theory, sustainable at momentum. One of the things that popped up was, and we see this across the board, is people would say, we've done a bunch of really great suicide prevention work in preparation, and yet we would see staff saying, well, we need this. And somebody would be mad because they'd spent a bunch of weekends and nights and they made this, and no one's using it, right? And so what we were able to do is actually go in and say, look, one of our struggles out there is almost like a user interface or kind of user experience problem, where here we are in Silicon Valley, but we've got, I'm in the middle of a crisis, and this thing that I need is buried 3 layers deep on some shared drive somewhere that sometimes I can access and sometimes I can't. And I don't know it's there to begin with. So even if I knew it was there, I probably couldn't find it in time, and I certainly don't even know it was there. So we were able to go back in and say, okay, look, from a user perspective, who are the users? Well, I'm either coming to this place needing resources to help people. So this is where we would have stuff of this, hey, here's the initial thing. We'll talk about this more next session, but here are a bunch of resources for you. Okay, you can just have these right there they are. Resources for staff. So this is where we had to go find a place where staff could get support following a death by suicide that is external to the organization, right? It's great that we have internal supports in an organization. A lot of folks want to seek support outside of an organization. Credit Bill Wilson Center because they became the answer to that. But again, that was one of the situations where here we had their services in the county available, and folks just didn't know about it because, to be honest, most of their day-to-day life, they didn't need to worry about that until they do. Right? And then tools for clinicians is specifically the assessments and things like that. That tools page goes into this. The Columbia can be linked here, and again, I think we have 6 or 7 language translations that we worked with the Columbia folks to get. And the folks can get the cars and then link out there to training. This is an example of this kind of stuff that we're doing for folks. Here's an idea. It's a more complicated idea of why is it that when someone goes from clinic to clinic to clinic, there's nothing that follows them. There's my 10-minute timer, so I'm now going to fail the 10 minutes by at least 3 minutes. Can we have some form of a dashboard that follows them so that we're not repeating effort? The big important thing in this has been it's easy to go in and do consultation by just making a list of additional stuff that people have to do, and that's not sustainable. What we have to do is find inefficiencies in the system that we can tweak and change to get people time back. So we try to always be at least burden neutral in recommendations for change. Here were Momentum's numbers. The blue line is the pretest. We identified role definitions, who does what, communications and handoffs, ethical legal issues, training and resource issues, and underserved marginalized populations, cultural integration as the relative challenges that were going on there. We target them for the, this is probably about 8 months in between pre-test and post-test, and the post-test is, so we made objective and subjective changes by targeting what Momentum told us they needed and doing it in a way that they could get excited about. So we have these great data. We go on the next idea, and Dr. Miller can talk about this. The idea right now is how do we do this without the consultation team being right there in the mix so much? What's sustainable for this year? And we'll talk about what they've done this year is they've been able to replicate the training part of it with some additions because access to training is not easy. You may have heard that there are a number of vacancies out there and that positions aren't filled. People have high caseloads, and even though you make a fantastic training, it doesn't mean someone's going to be able to go. In fact, we like to say if we have the right people in the room, they aren't going to be able to stay. And that's just an idea of we need to be ready for the fact that if you're the right people who we need, you're not going to be able to sit down and stay. We need to be able to think about how that's going to work. We take all of that and we take it over to ACCI when things are winding down at Momentum, and we show ACCI what we had done at Momentum, and they said, that's fantastic. Let's just do exactly that. That's exactly what this community needs. Let's do this. And this is all in the context of forming the working committees that are going to be there. We said, yeah, sounds good. And let's go ahead with the needs assessment. Let's send it out and again, try to get penetration into every level of people working at ACCI. If you come and you're working at ACCI, we believe that you want to do a good job in this area. And we want to hear from you no matter who you are. And we do that, and it comes back, and it looks like we could do copy-paste from Momentum to ACCI, but that wasn't what we needed. What ACCI needed or found an opportunity to do is to actually, from the bottom up, gut their entire policies and procedures related to suicide prevention and start from scratch and say, if we right now, with what we know in 2023, we're going to write a suicide prevention policy, what would that look like? And this is full of days of people saying, well, we can't do that because this clinic's going to need a different policy over here and all that kind of stuff. And part of the job of the consultation team was, well, what if we did do that? What if we were able to do that? And you'll hear, I think, a role of, there's a benefit to having an external person who can just try to push us beyond some of the perceived roadblocks. So the stage is right now that I think we've drafted this. It's been around clinical staff, and I think it's illegal. I think I owe somebody an email. So we are at the stage now where this is about to become our standing policy that includes things like policy. And if you don't do what's on this section, we're not following policy, and we're possibly in legal trouble. And clinical guidelines, which is different. So for example, in the policy will say use one evidence-based measure in the assessment of suicide risk. The clinical guidelines will say you could fulfill that with the Columbia. You could fulfill that with the CARS. You could fulfill that with the Firestone. You may fulfill that with any number of things that you are trained to do. We don't want to pigeonhole you in that way, but we want to set the bar at an evidence-based measure. Dr. Loth has, I'm going to say hacked. You've gotten in and tried to get the electronic medical records to pre-populate a lot of the documentation that we want in the form of smart phrases or whatever it is that your EMR calls it. This is going to be one of the time saves, and it's also one of the places where we've recognized we could really use some probably funding to buy tech folks to come in and change some of these systems or give us modifications or plugins or add-ons or whatever. So this is some examples of that. ACCI did like the idea of that dashboard, the user-friendly dashboard where folks can come in and find their stuff. And that is something that we did replicate at ACCI. This is their version of it. Their needs were a little bit different. They wanted some of the apps up front, some of the phone apps right there on the front page. And then just similar data to ACCI. This is ACCI's pre-test, and we don't have post-test yet. But the thought is that what they needed and what they were going to get excited about was that policy development. And then once we know what we would train people to do, then we'll look at another year with a 6-month rollout or a 6-month package. But so very customized and different for the folks. Got some qualitative data there, but I think at this point, let's get over me have my colleagues come up. Knock around with the microphone a little bit because we're recording. So, anybody want to start with just reactions to what I've said so far, or do we want to get more into the prompt questions? Do you have any corrections or any, that's not what I thought happened? Any changes? It sounds okay? All right, validity fact checking, live fact checking. All right, we're doing okay then. And in about, let me get them started, and then maybe in about 10 minutes, we're going to open up for questions for folks to ask. Sound good? I just made that up, so if you have a really burning question, just go for it. We're not going to kick you off. So a couple things. Can you tell us about the suicide prevention environment and needs in your agency? And then what did you learn about your organization's strengths and needs and challenges during this process?
Sure. So I mean, I think you covered a lot of our needs assessment results. I would say that it's in recent months, suicide prevention has become very top of mind at our agency. And I'm not sure if this is going to be a continued trend or just a blip on the screen, but we have had a dramatic increase in suicide losses, related losses this past year. So it's been hitting our staff hard, and the focus has been on what can we do? Can we do more? Focusing on the suicide prevention. And really the staff support after a loss has bubbled up as a huge need, which we actually benefited, I think, from all the work that we did the previous year with our focus on suicide prevention, that we developed, systems and resources around staff support, to move in quickly and not keep our staff us after a loss. Proactive in reaching out and creating venues for processing either individually or so that was a big need that was identified through this and actually came to fruition as something we really relied upon this past year. But yeah, the need for what to do in a crisis, I think understanding workflows and who does what in a crisis situation, and how we can have that flow smoothly so that it's not a traumatic experience for everyone involved. That was another thing. But I think you covered basically in your summary the things that we're identifying to address them. The needs assessment is very helpful to get staff themselves and what they need rather than us deciding what's needed.
Thank you. Within ACI, the needs assessments really shed the light on a lot of representing the voices of our staff. The workforce that was created was a lot of managers, and we had the impression that a lot of the needs were geared towards different types of trainings and reinforcing some of the information that we felt we saw. But then with the needs assessment, the staff members were feeling like they couldn't find the information, and I think many agencies probably fall into this where we have a lot of trainings, but due to staff turnover, we feel like we did give the training, but then it's just the new staff and new groups that are coming through may not have received that information yet. And so the idea to really do a consolidated place that was easier to find, like the managers knew where the information was, but then the staff really had to struggle to find it. So I thought that was great. And the other piece was we had a general idea, like theoretically, it makes sense if somebody is suicidal, you do the safety planning, you collaborate or coordinate with your clinical supervisor. But I think the part that was missing was we're pulling in information that we probably learned in school, but never really solidified with the agency's policies and feeling like we have a strong holding with that. And I think this provided a really great structure to have in place just to make things more consistent. And I think like what Dr. Miller mentioned with streamlining the process just to make it smooth and easy for everybody when it does come. Because if the client is in crisis, it's so easy for the providers to feel very stressed and for the providers to forget some of the things that they were given at orientation 6 months ago. So it's really difficult to hold them accountable for something that they weren't able to apply early on. And so I think just reinforcing the information has been good.
So I'll run through these. There are a little bit of overlap, so feel free to ad lib a little bit. But what's the focused work on suicide prevention done for the agency, and what kind of things? So you're already kind of going there.
Yeah. Well, I think the key things it's done for our agency is it improves the quality of care that we provide, which is first and foremost of importance to us. But I think it really helps the staff to feel more supported, to feel more confident and well equipped to do the work that they need to do. So I think those were the key benefits of doing this work. One of the things I've learned is that there's making change and maintaining change, and those are two different things that each need separate focus and attention. So we did a lot of work the first year of making change in how we focus on suicide prevention work, how we train staff. But then, there's staff turnover and people forget, they get busy, and it doesn't. Fortunately, suicide doesn't come up that often in day-to-day work. It comes up in crisis center. So you have to, I think, repeat the training, repeat the information, and consistently renew the focus for people.
Okay. And I don't think I mentioned it to you yet, Dr. Weaver. We are actually in the process of planning of training some of our other departments about just suicide awareness and suicide prevention. So within ACCI, we're a multi-service agency, so we do have a specialty mental health component, but we also have an FQHC health center, which the providers are really terrified or have a bit of anxiety in terms of when suicide presents there, because suicide doesn't only come in at the mental health side, it comes in any of the avenues. And so being able to support them at many levels. And I think with this project, with our focus on the policies agency-wide, I think it really helped provide a structure for any provider. And I think that's probably where we're continuing to build off of and grow. And it really made a continued impact as in terms of confidence. I think it really eased the anxiety associated with addressing suicide.
Okay, thank you. Maybe last question before we turn them loose on you. So I didn't mention this so much in the way that I talk about it, and my colleague Joyce would kick me under the table for this. But from the foundation of the project, being culturally responsive was a critical requirement for us moving forward. For folks who don't know Joyce Chu, she is certainly the local expert on diversity and suicide risk, and certainly among the top national experts on diversity, culture, and suicide risk. So we have the benefit of having her right here with us and working with her hand in hand day to day. But she really is a force to be reckoned with in that area. So the foundation of the consultative work was really in community-based participatory research principles, which is the idea of everything as the consulting team is just support staff to the agency. So we come in, we know how to leverage the research methods. I didn't go into it, but the data were inductively and deductively, qualitatively coded. All of that stuff is very sound, and it has to be driven by what the agency wants to do, and these are examples of how that works. The focus on culture and diverse populations in the Bay Area is it doesn't need stating that we sometimes take it so for granted that we don't do the best at it. So we wanted to call it out and say it out loud and have it run as a theme, again, as you saw up front, both in the policy that we're developing for acting and the training work for momentum. So the question here is, why is a cultural approach needed in this work, and how can cultural infusion be actualized?
Those are great questions. They're tough, though. Well, it's needed, obviously, because we're dealing with such a diverse client population and diverse staff treating those clients, and they're not always going to match up in terms of their backgrounds. And this assessing for suicide risk is so critical. You really need to be asking the right questions and asking them in the right way to get the information you're trying to get from the client and to connect with them in the right way. supported and relied on. So I think we can, if we come at it with a one-size-fits-all set of questions that we ask, you're not going to get there most of the time. You know, you need to understand where this person's coming from, what types of triggering you're going to do with the question that you might ask, and what they might associate with that question. Fear of incarceration, fear of hospitalization, fear of stigmatization, fear of being disowned by their family, whatever. You need to come at it with that lens. You need to see questions through their lens, and that's why it's so important. How do you infuse it is very hard, but the trainings that we started to institute, I think we're trying to get at that, bring that awareness of what different types of backgrounds might bring to bear on the situation. So,
Dragging the wire. For us, we are very known for providing services to clients who are monolingual. We have a Center for Survivors of Torture, so oftentimes our referrals are with refugees who don't speak English, and a lot of our former name is Asian Americans for Community Involvement, but we serve all languages and all community members. It's just the starting of it, but oftentimes the referrals for Asian languages also come to us with our providers speaking the language as well. I think what helped with this whole project is being able to become more aware and recognize some of the other factors that are missed in some of the standardized screening questions that we're not considering. And I think a big example of that is like any issues with assimilation or even looking at the family dynamic and the impact of that, what that means. Oftentimes stigma is, or there is stigma, and being able to navigate that with the client. And I knew I had a thought, but I think your question was how we're addressing culture within actualize it. Yeah, so I think the work group was a really nice setup in terms of key stakeholders. So my background is primarily an adult. So I had like no vision in terms of how this would impact children or our LGBTQ community within the youth. But in our team members, we had representatives from, I think one of our members was within our other work group for LGBTQ, and another was with a program manager and associate director for the youth programs. And they were able to speak up and highlight when things weren't working or what things might not apply or things to consider. And so I thought that really made the work so much more meaningful because it would be applicable to all the other programs within our group. Or else I would have missed it. They really, how do I say it? They were. It was a good mix because they caught my blind spots, and I think that's probably something to consider.
All right, so we'll open up to questions. Probably the best way to do this, rather than try to drag the mic around, is for me to repeat the question. Any questions? Yeah, so trainings or procedures to help staff address the intermittent nature of suicide risk if it's not something that they're focusing on, like for example, in a crisis.
that's a wonderful question. And I mean, aside from I'm coordinating right now a training on we'll run through the panel with our staff, other staff about their anecdotal experiences and how to handle things. But aside from that, I don't think we have actually what you're talking about, which would be like a drill, almost like a safety drill That's a great idea. That's something I could definitely think about, but I think that's a great suggestion. I don't know if you already.
It's not formally, but I know we're growing towards that trend because we're recognizing there's a big gap in terms of being able to apply the content that you learn. So our agency, we have an Officer of the Day program where different licensed providers are able to cover that day shift for any type of crisis that does come by. And so once a month, we do meet up as a team to go over any items that we all need to become aware of or share the experience, so at least we can learn from the other person in terms of what has happened and what procedures took place and if there were any changes that we plan to make. In addition to that, we do have clinical supervisor meetings that are also once a month, and that's where we try to highlight some of the key things that we want to reinforce within the staff members. And so it's a lot of trickling down, but I think we're slowly transitioning to either a quarterly or a lot more frequently than once a year to really touch base on the suicide prevention aspect. I think it just lucked out that we're in a transition with updating our EHR system. So the timing is that we have to give them an update on how the new system works with suicide prevention. So we're planning that already as well. So they'll be getting a refresher, or for some of the new staff, a whole new training on suicide prevention.
I'll talk from the perspective of the consultation team for a bit. So one of the things that we thought, Joyce and I think as academics thought that we roll in as professors and we have a talk. If you feel that they will come. And that was our early days of learning that not everybody can do that, right? More importantly, even if you are, I think your question is interesting because you're getting at you asked the question, how do we get people more frequent exposure, right? Not how do we make their training accessible when they find themselves exposed, right? And we have been taking it from that latter perspective. So your question and your perspective is interesting and it's going to be food for thought. From the latter perspective, we realize that live trainings essentially it's not enough for folks to have. More importantly, there are probably a couple of points where we grab folks. One, when they need CEs for their rotation. And then two, when folks are in a crisis or get that client where this is a more live piece for them and want some support. And for that second part, a 2, 3, 6, 8-hour training isn't necessarily what folks need. So coming out of the era where we all had to go online, and I was a prior card-carrying member of online training is bad and in-person training is good. And I had to convert, and now I'm owning that conversion. And any topic that you think about, I can find it on YouTube. My stats students hate that I tell them to go to YouTube, and they say I'm not paying you to tell me to go to YouTube, and I'm saying but I can't ignore that Khan Academy explains this way better than I can. So we need something like that model. We need podcasts. We need short videos to tell you little reminders, booster things that we get, that anyone who needs to can find a way to kind of immerse themselves in that and have that stuff accessible. This idea of 6, 8-hour CE training is great for one end of training access. It's completely not built right for the other end of access. Yeah. The question is, let me see if I can paraphrase. So the question is, how is it going with the implementation of a standardized measure? Because there just are different needs and demands for different ways that patients come in. Let me set a little bit of context here from one of the things that is a heavy piece of our training when we come in and do work with folks. There is a distinct group of folks for whom their suicide risk is not fronted with depression. So it is not mental, it doesn't look like mental illness. So depression screens, PHQ-9s or PHQ-8s can fail to pick up and flag somebody for further screening. So you alluded to this issue of it feels, you didn't say heavy-handed, but I'm going to say it feels a little heavy-handed to bring out a Columbia for every single patient. So what do we do? How do we strike that balance?
So I'll start by saying that we're a very large agency with a lot of different levels of care and different types of settings, so residential, outpatient, and outpatient. So I don't oversee all of the staff protocols and all those programs, so I can't speak to what they're doing in all of those settings. So I would not think that they're just administering the screen to everyone that walks through the door. It is available, and I think, as Chris mentioned, it is appropriate and indicated for certain situations. So I think the focus has been more on offering these trainings. The self-paced ones in particular can offer a lot of guidance to staff on when it's appropriate to do what actions needed in what types of situations. We're really focusing on training their clinical skills and assessment and intervention. So we have made it available, easily available and accessible by our website. So I think there's different pieces that need to happen. One is the training piece, and then one is available. We have, we're building it into our, I think we have built it into our EHR.
Thank you. Similar to us, I don't oversee some of the other programs, but I speculate that it's not being done for everyone, but it's encouraged when it's relevant or utilizing that clinical judgment piece. With our old EHR system, nothing, I don't want to say it's nothing's in there, but it didn't allow us to have some of those screeners readily available. So you have to search for the PDF in some folder that's within the system and go look for it. And of course, when you go in to see a client, you're not anticipating that you'll need all these different screener forms. So it's always a struggle. But with our new system, it is readily available if they need to click on it to expand more. We do regularly, at least for some of our programs, it's weekly to monthly that they get administered the PHQ-9 and the GAD-7. And sometimes that's also, it helps provide some type of alert. But in terms of the CSSRS, I do like that the Columbia helps us gather some of the information that we probably would be asking as clinicians as well, in terms of how long they've been experiencing this, if there's any plan or intention, and if they things along that line. But I think it is definitely clinical judgment, and I think like Dr. Weaver mentioned that with our policies and procedures, we mentioned that one screener would be utilized. It doesn't necessarily have to be the Columbia, but it's just encouraging folks to know that there are some evidence-based tools that they can incorporate into their practice.
Yeah, go ahead. Yeah, the question is there value in doing some assessment of what tools are being used by what agencies and why they would be using them? And certainly, at least from an academic perspective, it's a heck of a curiosity, right? So how is it that folks tend to be there? It's something that's been on our minds. Dr. Chu and I are both psychometricians. We both make psych measures. I'm a regular reviewer for psych assessment. I know I taught um, psychometrics, so I'm a big fan. I am in the club of I think that if something goes wrong and you don't have any evidence-based measurement in the patient's history, it's a liability risk. My sense is anecdotally from doing this with these agencies and close to maybe a half a dozen others at this point, is that folks are leaving it to the clinicians. And so clinicians are probably bringing what they were trained to do, which isn't necessarily a bad thing because sometimes we do see places where they will mandate the use of a particular instrument and sometimes have gone through years of discussion to come to that instrument. And then Dr. Chu comes out and says, oh, this instrument doesn't quite pick up older Asian American risk among those folks. And the institution has trouble changing because we spent tens of thousands of dollars to decide to use this instrument. So that is some of our rationale for the way that we do it is to say that an evidence-based instrument will be used. And there's tons of language to specifically empowering and expecting clinicians to make adjustments for cultural demands of the assessment and the norm groups, but the assessment was made on. And then we're also somewhat seeing that as potentially, hopefully, future-proofing the next person to come down the road and say, here's a better mousetrap, and how do we integrate that and do that while still confining them somewhat by saying in the form of clinical guidelines, here are measures that we like. Yeah.
Well, I'm not an expert in care, so I would have to go back to our programs that are, but it does, yeah. I'm not a specialist, I'm so sorry, but yeah. So I don't think I can answer that effectively, but there would be different approaches to addressing the risk assessment. For sure, yeah. And it goes back to the culturally sensitive, not a one size fits all. I think that would be the risk of saying everyone has to get this done, right? If it's not so I can't tell you what they're doing, but I know that there is a specific.
I'll just comment in general that screeners are just one aspect of our assessment too. So what I really liked about our clinical guidelines is that you're factoring in the screener, but you don't necessarily have to agree with it. Like we can anticipate with the feedback that we're getting from the client that if the screener comes out mild, but we sense that it's moderate, then there's other components that we're adding into it. So I think with children too, it's really looking at, it's so multi-level in terms of the environment that they're in and their social settings as well as other compounding factors that might be contributing to their risk. And so when we think about it, like, I don't think the CSSRS incorporates the challenges of navigating peer pressure with coming out trans, I think, from our keynote speaker. And so we can probably take that as a factor in that this CSSRS missed this component, so we suspect that it's more moderate than mild. So screeners are a great starting place, but we can always expand from it.
So I'll plug a couple of things. Anybody from Herd Alliance here? So I want to plug herdalliance.org as a fantastic, almost overwhelming resource center for all things suicide risk management in schools, built in Santa Clara County and for Santa Clara County. But their materials are spreading at least statewide, if not nationwide. quite quickly. So they have some detailed assessments. In terms of risk factors, the two big things that you see is that job stress for adults becomes academic stress for the kids. And then bullying and social things really becomes its own incredibly salient risk factor. And of course, including bullying online and those kinds of things. So there's some of that. For folks who don't know Joyce, so she is also the author of the Cultural Assessment of Risk of Suicide in Cars. She'll be here talking about Be Sensitive, Be Brave this afternoon. You can ask her about the cars. We shamelessly plug the cars in good conscience because it's, I think, the best measure for accounting for cultural variations in risk, and it's free. Much to her friend Chris's chagrin, who told her she should charge for that thing, she has put it up absolutely for free for folks, and the publications have been out for a couple years on the adult version now, and one is under review for the adolescent version. So it's coming. More stuff is coming down the pipe as well. And then a quick note about the importance of assessment, even beyond, I want to say, the Columbia screener. One of the things that we see in a lot of organizations is folks know what to do when there's not a lot of risk. We know what to do when there's imminent risk. We're not comfortable, but we know what to do when there's imminent risk. We don't know what to do when someone's moderate risk. And this leaves a lot of gaps in things like, well, they just came back from a hospitalization. What's our reentry plan? What does that look like? How are we going to treat them? How are we going to not wait until that happens again and work on this right now from today moving forward? And we call that kind of the moderate risk group, or almost the middle class, right? The group that kind of gets forgotten because they're not treatment as usual. They're not where we legally have to know what we're doing with them. But how are we going to understand it? And that's where the deeper, more complicated assessments probably the answer. In the old days of violence prevention, everybody got anger management, and that was okay because anger was a lot of people's pathway to violence. But now we do deeper assessments, and we see, is it anger? Maybe it's not anger. Maybe it's impulsivity. Maybe it's other things. Maybe it's some. And so the same kind of thing applies here. It's the deeper assessment done probably over time that's going to inform that. So again, coming from a fan, huge proponent of good, culturally based screening and yeah, so it's helping staff understand and appreciate and plan for that moderate level of risk, part of the staff support.
Well, there's a lot of good questions in there. I mean, one is about training on what to do in those situations, and one of our trainings that we offered was suicide prevention, which had a huge portion of our staff attend. It was very, very helpful. We've also had sessions on brief CBT interventions for suicide. So you can implement trainings to help people understand what to do with suicide risk. That's not immediately. But then there's the piece about supervision, right? And I think so we offer robust supervision for clinician staff, therapy staff, and then for the physicians, we have a monthly conference meeting where people come and just. Sometimes it's really just about processing the challenges of some folks that they're working with. but it's also about getting support and advice from colleagues. And I think that having venues like that is important for the space where people feel like they are part of a team and not just working in isolation. So that would be, something I would recommend everyone have attention to is what level of group supervision and processing involves.
I think this group actually gets it really well. I will say that the hospitalization is a really good space for acute suicidality, but oftentimes in the community, what we get is a lot of chronic suicidality, right? They're not quite appropriate for the hospital, and sometimes the hospital setting isn't even the best treatment option for those with chronic suicidality. And I feel for our clinicians who do hold on to those clients. I think what ends up happening with our team for my integrated behavioral health program, I'm not too sure about the other programs, but it's a lot more team-based approach in terms of surrounding that client with support. And so one person, I think we call them patient touches of how many times we're contacting and checking in with them, that it does require a little bit more work, but then it also sets us up for knowing that we're doing what we can in terms of mitigating and putting all these efforts and seeing how to get them into a space where it is a little bit more manageable. But sometimes they don't like the hospitals, and sometimes the hospitals don't really treat our clients the best way that they can. And I think it's a work in progress on both sides. But I think the support is there as long as we're focusing on the needs of the clients.
Last question. Client? Yeah, so how much is the clients, what do they have available to access going into the initial assessment and evaluation of their risk? Yeah, that means very different things in Santa Clara County and Humboldt County, and yeah.
So what's the specific?
Yeah, so the specific question is are we factoring in that moderate risk group? Is there some way to be factoring in what resources are available to them in the setting?
Yeah, for sure. I mean, and again, this is part of, we can't be sitting with our providers in every visit and give them, this is what you need here, but we try as much as possible to educate them about community resources like on our SharePoint site. I've been on it many, many times, and, I'm like, oh my God, that's great. Flyers and resources in different languages for clients to access, local organizations and hotlines that they can access. We've been really trying to get the message out to our clients about 988, what that can do to help them in a crisis situation. So it's really just about making sure these things are easily accessible for our staff to then be able to disseminate to the client, and then just repeated training, repeated education, repeated advice during team meetings, right? So just really trying to create a culture around suicide prevention, what you need to know and what you need to do.
And I'll briefly comment too, 988 is like the biggest one that we kind of automatically implant as a type of resource. When we first started revamping our EHR system, the only resources there were all the national ones, and we recognized there was a need to indicate and list out a lot of the local ones. And I think our booklet too also has like a list of all the suicide prevention local resources on the back. I think we forget to highlight our own agency as like a general source. I know we're not always readily available. We do have an after hours line. We often encourage people to utilize 988 if it's more of an urgent need. I think the other highlight that we got from the consultation group are a lot of these different apps to also include to teach our clients that there's other tools and resources available to them when we're not available for them.
And I'll just make the parting final comment on that I think what you're getting at is critical. I think that's actually a piece that's held a little bit more by the consultation team as we go out to different agencies who themselves live within a certain set of things that are available. If that makes sense. There's more variability agency to agency than there is within. Yeah, we wouldn't know the back end of the data yet. I'm going to let folks go because we don't want to be the folks who made you late for lunch. But we will stick around and ask questions. So come on up and chat with us. Thank you all for coming, and thanks for being out there.